Okay, merci Guy. Again, I'd like to point out that I stand before you not as an individual who is interested in tyrosinemia, not just as that, but also as the representative of a group of professionals throughout Quebec who have worked very hard for 25 years, all together by the same protocol, to allow me to present this to you. Not the least of whom is Jean La Rochelle, who was very important in starting off the Quebec NTBC protocol. So these are my disclosures. I've worked on expert committees in Europe and North America to formulate treatment guidelines and to provide continuing medical education to various groups of physicians, and have a grant from industry for assessing the psychomotor development of tyrosinemic patients. And when I looked over the principal issues that were necessary to be addressed, I realized that they included neonatal screening, the patients who are acutely ill, what really is optimal for treatment with NTBC, with diet, with what happens to the kidney in the long term with these patients, should patients who are transplanted be on NTBC, what happens during pregnancy and with the other great challenges of being an adult, such as getting a job, holding it down, and living a normal lifespan. And then I looked at the group of people who were happy enough to have with us today, and I realized that every one of these topics was already going to be covered, and so that I had basically nothing to tell you. However, I will fill the time with a couple of points. The first thing was, why did we do the Quebec study? Why didn't we just treat the first patient that came along and the next one and do it? Well, the reason is that tyrosinemia is different in Quebec than elsewhere because we had these children who were detected by screening. These are not the same biology as a child who is detected later on after having developed symptoms with the liver or the kidney or another organ. They're different. And we couldn't really use the information from other places to directly apply to our patients. Secondly, we had an obligation as academic physicians and really as physicians to try to collect the data together in order that we could explain to people elsewhere how our patients with tyrosinemia did here in Quebec. But also, a very important point, every bit of data that we get with this study is synthesized, and then it's fed back to the new parents who come in with their little baby, 3 weeks of age, it could be in Quebec City or Chicoutimi or anywhere else in the province, and nowadays the physicians can say something to them that we could never have said 25 years ago. We can say that, look, if you do this treatment, then your baby's not going to have liver decompensation, for example, will never have a neurological crisis. And it's very, very important. And it's very important as well for the patients to be able to group together all of the information that we can have on them in order to help and to counsel patients all through Quebec and elsewhere in the world. So that's why physicians across the province have gone to such problems. Okay, let's just get on with it then. This represents the first steps of the Quebec NTBC study. The patients are detected by screening. They're referred to physicians anywhere in the province, and it's all the physicians in the province who see patients are part of the Quebec NTBC study. So they always see, and they speak with me about the patient. And the first thing we do is to test the liver function. If the liver function is normal, the child is followed closely, but the child is not put on NTBC. There's an interesting poster about these patients, but I'm not going to talk about them. We're going to talk about the ones on the far right of your screen that get NTBC. Oops. These are the numbers. So far, we've had 106 patients referred. 9 have not been treated. 97 have been treated. And those that were treated above 1 month of age, 29. 8 of them had to be transplanted, 21 not. And then at the bottom, those treated below 1 month of age, none have had to be transplanted, and you heard the good news from Dr. Dubois, from Dr. Halak, that their liver seems to be doing normally. For a total of 89 patients we currently follow on NTBC. Now, what actually happens? So the child is seen. If the liver function is abnormal, the child is hospitalized for 3 to 4 days, usually 4 days. And during this time, a lot of things happen. There's collection, there's sampling of the urine, of the blood for the samples which are necessary, and we will use these samples for the rest, and the results from these samples for the rest of the child's life as a comparison. The first samples are important. And then they also have the very important thing to meet with the nurse in one of the centers that handles this, the dietitian, with the physician, and also with the pharmacist often, and to learn the regimen, to learn the diet, to learn about the pills, to learn about all this. And then by the time they're going, the parents will have gotten over the initial shock. Although it's true, one never gets over the shock, I know, but they will have gotten over the initial stage of the shock, and they often will have had an ultrasound as well of the liver. So a lot of stuff will have been done, and when they leave, they'll be able to contact one of our group at any time. Then during the first 3 months, the children grow so quickly that it's outside the protocol, but the physicians follow them very closely and very, very serré, very, very, very closely. And all these things are checked. And then in the long term, some of you might recognize yourselves in these photos, which were taken a few years ago. And I'll come back to that. But after the first 3 months, we have a regular series of follow-ups. And every 3 months, there's blood and urine tests. Every 6 months, there's an ultrasound. And every 12 months, there's an MRI and a nutritional evaluation. And plus, they're seen at Ste-Justine by the group of people who are presenting today. And every few years, much less now than previously, we do GFR and we check the heart. So far, there's good news in that respect. So it's a multidisciplinary effort with the physicians outside Ste-Justine, the group inside Ste-Justine, working together. And all along, we adjust the diet and adjust the NTBC levels, NTBC dose, according to the values which we obtain. What is NTBC? It's this compound here. You've heard a lot about it. The one thing I would just like to mention is that it's rather surprising, because the scientists tell us that NTBC, you only need about 1/1000th of the amount of NTBC to inhibit the enzyme for hydroxyphenylpyruvate dioxygenase, 1/1000th of the recommended level that we keep in the blood. I haven't explained that. Scientists can talk about this. We can discuss it. But de facto, we checked to see what level of NTBC was necessary to suppress the levels of succinylacetone in the blood and the urine of patients. And so what we did was we looked at the succinylacetone levels at the same time as we looked at the NTBC levels for several months in all the patients in this study, and we did this several years ago. And as you see from left to right, you have the levels of succinylacetone in the blood that were the highest, greater than 80 micromoles, and then progressively lower. And we saw that, and this was also done in the Swedish study by Dr. Holme, and who had a similar result, that when you get around 50 micromoles, the succinylacetone in the blood and the urine starts to go up, and it becomes significant. And so for this reason, we have attempted to keep the succinyl acetone levels above 50 micromoles, and that's this reasoning. We also aim at 200 to 400 of tyrosine and try to keep the phenylalanine above 25 at all times. These are our present recommendations. So what sort of dose of NTBC is necessary to maintain this? Now, I don't want to go into a lot of detail because Susan Atkinson's going to talk about this later, but I'd like to make a couple of points. The first is on the left-hand side shows the level of the dose per kilo of NTBC versus age, with birth being at your left and then as they get older on the right, and the axis is in years of age. And as you can see, there's a general tendency to decrease. And we can talk about this, but I don't want to have the red flag again, so I'm going to keep on going. Now, the second point was that this decrease with age, I felt was not truly reflecting what I was seeing in the clinic, but there was another phenomenon, and that obesity, in fact, in our group of patients is becoming quite frequent. And I know that Manon Bouchard will be speaking about this, but it's an important consideration, and it's something I think the dietitians and the physicians will have to address. And why is this? Because now children with NTBC and adults have really normal liver function, and we're looking at a long term. And so as Dr. Halak mentioned, one of the main problems in their liver might not be tyrosinemia, but might actually become the steatosis that accompanies the obesity in many patients. So far we haven't seen much of this, but it's starting. And so we think it's an important consideration for the long-term follow-up of patients with tyrosinemia. When we look at the dose per square meter of surface area, which is a better indication and sort of relieves the bias of increased fat mass, it tends to go around, it tends to go around 30, which is approximately 1 milligram per kilo if you translate that out in brute force. And it tends to focus a little bit too, it's less dispersion. So it's still, even after all these years, it's not a perfect indication, but we have the impression that, the dose relates to the fat-free mass of the patients. What about kidney function? So I was not going to speak about this, but one of my colleagues, Raymond Lambert, was unfortunately unable to come and discuss his long-term study of the GFR of all of our patients. So I'm using an older slide, which actually reflects what Raymond is finding with a much finer analysis. And as you can see, these are the GFR levels of patients on NTBC, and there's certainly no decrease. And so there's a bit of dispersion. We have better figures now, but in fact it's quite stable. And even one patient who was going into kidney failure at the time when she was put onto NTBC, when she was a bit over 20 years of age, subsequently had an increase in the glomerular filtration rate, and probably this was a major factor, we think, in her being able to avoid having a liver and kidney combined transplant. Now, these are two of my favorite pictures in the whole world, taken just at a clinic like that several years ago, because we had to convince some bureaucrats that we actually had patients. And all these kids have tyrosinemia, and many of the parents in the audience might recognize themselves. And I'm sorry if you do, but for me, it's one of my favorite pictures, and I almost shed a tear every time I see it. Now, I'm not going to talk specifically about psychomotor outcome. There's some scientific work on this which is going to be done, and it's a serious situation. It's a serious question that needs to be followed up. Some of the children do have attention deficits. Some of the children have performance in school which is less than we would like. Others are doing fine. I mean, I had a clinic recently when I had, nurses and people going in for social work, and, just a normal clinic of people who didn't have any problems. But again, I repeat, it's something which is serious enough to merit direct scientific investigation, and we have talks on this a bit later on. I'm not going to talk more about it. Finally, pregnancy, and Hélène will be bringing this up, but I'd just like to mention the point that pregnancy is a delicate period of people's lives, going from the egg until birth, and sometimes the fetus is susceptible to problems with development that we don't understand. So right now there's very little information about pregnancy, and so it has to be a concern. Now, it's not possible not to treat patients during pregnancy. The risk of having hepatic problems would be much too great. To date, there's been, well, I said no, but there's very little fetal toxicity in Marcus Grompe's studies and many other studies that really relate to prenatal toxicity of NTBC. There's not enough knowledge to say there is no problem, there is no risk. And finally, of course, one would like to have the succinyl acetone the lowest possible and to have perfect control of tyrosine and phenylalanine throughout the pregnancy. So ideally, the pregnancy should be planned if the patient wishes to go ahead, and the level should be closely monitored and controlled during the pregnancy. Now, Dr. Augier will give us some examples. It's not always works out. It doesn't always work out that way, but those are the recommendations. So far in Quebec, no patients on the medical treatment have had pregnancies, and Dr. McKiernan discussed the pregnancies in the transplanted patients a bit earlier this morning. One of the most important things, to my mind, is the fact that the disease paradigm has changed for tyrosinemia. In the old days, it was an intensive care disease. I used this slide earlier, but I think it's important. Children, we were trying to save the children's lives. But now, it's an outpatient clinic disease. Unless they're not compliant, children are doing fine. And so what we have to look now is getting long-term good outcomes, and we have to have finer instruments of evaluation in order to find small problems and to make lesser adjustments to treatment, probably, in order to have excellent long-term outcomes. It's very important psychologically that the patient who's on NTBC and then stops taking NTBC will not feel badly for quite some time. Not until there's already been some damage in the liver, not until maybe they might even have a problem. Two examples. The first one was brought up by a question from Dr. von Spronsen, and it involves what happens if the diet is not carefully followed. And in this slide is from an ophthalmological journal, shows a slit lamp examination. In the upper part, on the right, you can see how you have this branching structure in the cornea of the eye. And this is called a dendritic pattern. And then you can see the same thing, but with fluorescent staining. It does stain to a certain extent with fluorescing. And this resembles herpes conjunctivitis, and this might be treated by antiviral drops, unless the physician is aware, as I was mentioning this morning, that the patient has tyrosinemia and that this specific complication has to be reported back to the physician immediately. And if we know about this, we will seriously restrict phenylalanine and tyrosine, and it will go away very quickly. In our experience. Even worse is when NTBC is not taken for psychological reasons or simply because we have an adolescent who does not believe they have the disease. And it happens. We recently saw a complete neurological crisis, just like in the old days, in which the person was paralyzed and had to go into a rehabilitation center for several months in order to get so she could walk again. And this was simply because when she came in, it was as if she wasn't, her NTBC levels were not detectable, and she had a very high succinyl acetone level, and she developed a classical crisis. So the message to the families is that please take your NTBC. If there's a problem, talk with us about it, but take your NTBC. And the message to the physicians is that you cannot forget what tyrosinemia used to be like and just assume that you will never see the old complications that were described by Dr. La Rochelle and others. In conclusion, so neonatal screening plus nitisinone treatment before 1 month of age are currently the treatment of choice. The liver results show that things are stable to date, but the development of hepatocellular carcinoma must be monitored in all patients, and reliable methods are necessary for the detection of cancer. This is going to take research. Renal function seems stable so far. Psychological testing is in the works. No pregnancies yet in the QNS patients in Quebec, but some publications elsewhere that Dr. Augier will describe. Compliance with nitisinone in diet are essential issues for the long term, and the classic complications of tyrosinemia can still occur, so be alert if you're a physician. Same slide, I'd like to again emphasize the contribution of Dr. La Rochelle from the clinical point of view and of the team with whom I work in Ste-Justine, but really everybody in the province, because what you're seeing is a combination of what we're seeing today of public health, of excellent clinicians, of organization with nurses, of dietitians, of pharmacists, and everyone working together. So thank you. I don't think we'll take questions right now. Or what do we do? Do I take questions now and then, Alain, or do you want us to take questions together? Together? Okay.